Today, I'm going to present to you some how I use the Nanit to replicate some findings that I had from a study I did with children, toddlers living in very low income communities. And I had 110 in that sample, was interested in the findings, and so worked with Nanit to replicate that study. Sorry, I can't get my slides to advance for some. Okay, there we go. So I don't think I have to tell this audience that we know that it's an important and adequate amount of sleep for children's health and development. And that at this point, we're noticing that children are not getting sufficient amount of sleep. In fact, before they turn 4 years of age, it's thought that there's 25 to 40% of children are sleep deficient. And of concern is this emerging research that is suggesting that sleep health inequities are occurring as early as 1 year or before babies turn 1 year of age. And I was very inspired also by the recent publication defining sleep health in pediatrics as a multidimensional construct. And I think future of this sleep research is really being able to look at sleep as a multidimensional construct. And so thrilled that Nanit does offer the ability for us to look at these different dimensions. I found the review article on some longitudinal data that looked at what we know about sleep health dimensions and determinants. And they looked at this review was in Sleep Medicine Reviews in 2019, and they looked at longitudinal studies. And among the determinants, child age was the only one found to have sufficient evidence of determinants with sleep duration. So there's a lot of room here to identify other determinants of sleep health and be thinking about it again as a multidimensional construct. So in the work that I do, I think about these constructs, socioecological determinants may impact sleep health. So with this framework, we're looking at the individual in the center, the children, things like their temperament, personal safety and security, self-regulation, and their health. At the interpersonal level, things like parenting factors, bedtime interactions, then to the organizational level where healthcare providers, childcare providers, teachers, and extracurriculars may impact children's health. And then at the community level, crowded homes, neighborhood safety, and then at the societal level, school start times and work requirements, particularly school start times of older children. So the first study I had mentioned was an NIH-funded study looking at sleep, biological stress, and health among toddlers living in socioeconomically disadvantaged homes, where my first aim was to look at the extent to which socioeconomic adversity was associated with sleep characteristics. And just briefly wanted to highlight that the findings, I was surprised to see that, again, these children were 12 at this age that I'm reporting here. They're 12-month-olds, and their bedtime was at 21:53, and what we saw was a significant race and ethnicity difference, where white children were going to bed before 9 o'clock, and then we were seeing after 10 o'clock p.m. for Black and Latinx families. We also saw a high level of variability, though we looked at bedtime through the mean successive square differences, looking at night-to-night differences in bedtime over the course, and these data were collected by actigraphy, I should have mentioned. Looking at adjusted models, we then looked at socioeconomic variables that we had collected, and we still saw significant race and ethnicity difference. So I worked with Nanit to see if we could replicate this in a different population, a larger population with a more national representation. So one advantage of the Nanit, we were able to collect 2,200 responses in, I think, 2 days. We had responses, and these were surveys that were sent to, and consent forms sent to families with 12 to 30-month-old children who were using the Nanit. We had excluded anyone with children with a medical condition or that was associated with sleep problems, and the caregivers had to be over 18 years of age. Of those 2,200 families that had consented and participated, there were 1,500 that had sleep data, a little over 1,300 that had data for 4 or more nights. And so we had chosen to make that a limit criteria, including families who had more than 4 nights of data. We looked at, we had many surveys, the socio-demographic data that we collected in the first study, and then added something new to what I didn't collect before, which was the benevolent childhood experiences, which is sort of the opposite adverse childhood experiences. So rather than asking families about adverse experience they had in their early childhood, we asked the parents, what type of good experience did you have in childhood? And we wanted to understand sort of the positive balance of that. We looked at multidimensional sleep health, the total sleep time, latency, wake up time, wake after sleep onset, and sleep quality, as well as the number of parent visits to the child after bedtime. The distribution was 75% white families, 2.2 Black, 7.9 Asian, 8.7 multiracial, and 3% said had identified as other. The majority of the families were employed and married, and it was mostly mothers, and the mean age in the study was 17 months. So just to remind you that the bedtime that we had found, the overall bedtime was close to 10 o'clock in the families, 12-month-olds living at or below poverty. In this population, we found a bedtime that was before 9 o'clock. Their sleep quality was high. The total sleep time was 10.8 hours, and their wake up time was 7:25 a.m. So definitely different than what we found in the first study. Yet we did also find differences, race and ethnicity differences, even among this higher income group. So specifically, we found that there were differences between race and ethnicity groups. We also found differences in income brackets, as well as marital status. We found that children of single parents had significantly later bedtimes than children of married parents, and that children and parents in the highest income bracket had significantly earlier bedtimes than those in the next lower bracket, and then and more so in the 50 to 100,000 a year, and this is US dollars. In terms of bedtime, we were curious to see if there were any associations with the benevolent childhood experiences, and we didn't find them directly. When we controlled for them employment and income, we found that parents who identified as Black had 47 minutes later bedtime compared to those who are white, multiracial 34 minutes later bedtime, Latinx 27 minutes later, and other 31 minutes later. So in conclusion, race and ethnicity differences were found in bedtime observed in families across SES levels, both in the families I worked with initially, and then across the sample that we used with Nanit. We also found that income and marital status were associated with bedtimes. And these findings support the emerging literature that describes early emergence of race and ethnicity differences, and the strength of this particular study being able to objectively measure sleep in a large national sample. And in future work is needed to understand the cause of differences and identify intervention opportunities to eliminate these differences. Strengths of, sorry, that shouldn't say conclusion. These are limitations and strengths. Strength would be the videosomnography, large data set, the access to night data, and the ability to follow these children from infancy through toddlerhood, Nanit being contactless, and the ability to look at parent interactions, to look at the timing of when parents are going to the crib after bedtime. Limitations were that this was a cross-sectional study and that we did not have 24-hour sleep duration. And I just wanted to thank again Dr. Natalie Barnett, as well as the statistician that worked with her on this work, Thea Sanger, who's a PhD student at University of Michigan I'm working with, as well as the participants from Nanit. They were very active and engaging group. So thank you.